Good morning. See, happy March. It's still March. I have the opportunity to introduce today's Grand Round speaker. To start with, thank you to our exhibitors, Janssen Pulmonary Hypertension, who, if you have the opportunity, stop by and chat with them. I'm going to introduce Dr. Mary Noreen Walsh, who's kindly come to give grand rounds this morning. For those of you who don't know Dr. Walsh, she is a Minnesota native. We'll start there. Earned her undergraduate and medical degrees from the University of Minnesota. Yay, Gophers. Completed her internship and residency at the University of Texas Southwestern and her cardiology fellowship at Wash U in St. Louis, Missouri. She then went on to serve as assistant professor of medicine in the Division of Cardiology and assistant professor of radiology at University of Pennsylvania Hospital. And then eventually joined Ascension St. Vincent Medical Group in Indianapolis, Indiana, where she remains. Her expertise is in nuclear cardiology, heart failure, cardiac transplant, with a special interest in cardiobstetrics and women and heart disease. She is currently the medical director of heart failure and cardiac transplant programs at Ascension St. Vincent Heart Center and Ascension St. Vincent Cardiovascular Research Institute. She's the program director of the Advanced Heart Failure and Transplantation Fellowship and leads the Heart Failure Service Line. She is also the deputy editor of JACC Case Reports, associate editor of JACC Heart Failure, and a reviewer from multiple scientific journals. She, of course, has been active in the ACC both locally and nationally, previously elected as the president the president of the Indiana chapter, as well has served multiple committees and work groups. She most notably was the national president of the ACC between 2017 and 2018. Teaching activities include instruction of students, residents, fellows, lectures frequently on heart failure, heart disease in women, and topics in patient-centered healthcare. Actively involved in clinical research, heart failure, and systems approaches for quality initiatives in the practice setting. Multiple awards, too numerous to allude to all of them, but she is the Wenger Award for Medical Leadership in 2014 and Women's Day Red Dress Award in 2019. She is the lead author on the ACC's position paper on career flexibility in cardiovascular care, and she's going to talk to us today about burnout and career satisfaction and the need for cardiac flexibility in cardiology. Please help me to welcome Dr. Minna Walsh.
Thank you. Thanks, Ritu, for that lovely introduction, and thanks to all of you for coming out early for a talk on career flexibility. I am from Minnesota, and I wish the snow would go away, and so I'm sure all of you do as well. So this is a newer topic for me, and the college thought it was very important to have a policy statement. So I'm going to frame this first as why we need to think about career flexibility, and then we'll show you what the authors of this policy statement said. So here's kind of a tour of what we're going to look at today. So who we are as cardiologists, and this is, I know there's some medicine residents here, so we're going to talk just about cardiologists today. We're not going to talk much about the team either. How do we feel in our field? How's our field perceived by those of you who are residents? That's a really important thing to us right now. Then I want to talk about why career flexibility matters, and then how can we achieve it in our specialty. So who are we? These are data from the 2022 MACC Provider Compensation and Production Survey. MACC is a company. It is part of the ACC, and every year it asks cardiologists around the country, what's going on? How much do you get paid? Who are you? Not every cardiology group responds to this survey, but the vast majority do. So what figure 2 shows us is how many people responded and how many are in private practice versus integrated practice. So the green line is integrated practice. We all used to be in private practice many, many years ago. Not the university practices, but I'm talking about community practices were generally private practices. The vast majority are now integrated into health systems. This is how it happened. You see the crossover happened in 2011. So with more and more cardiology practices becoming employed into large health systems, this was largely driven by the fact the payment changed. The CMS changed payment, in particular around imaging. And so you and others, our group, fled into health systems. And so when we talk about cardiovascular practice today, that's what we're talking about. We're largely talking about integrated practices. This is how old we are. We are old, old, old. The majority of us are in those two middle bars between the ages of 41 and 60. So this is crucial in our field because we're an aging population. At the same time as the baby boomer population is getting and has cardiovascular disease, the workforce is on that same track, aging equally quickly. Look at, these are people who are full and part-time, and look at the percentage of people who are over the age of 71 who are still practicing. What about full call? So Dr. Katsianis probably wants to know who wants to still take call. Come on, can't all bail out at once. Look at who's still taking full call. A lot of people are still in the full call pool, even though they're over the age of 61 and even over the age of 71. So what about full call and partial call? I'm always interested in sex-specific differences, both in the disease, but also in our field and how we're employed. So more women than men take partial call or no call, but the majority of women take full call. But regardless, this is a really important piece, and we did a panel discussion at the CV Summit this year on call pay, on what people get paid to be on call, whether they get paid more additionally, et cetera. The vast majority do not, by the way, it's part of their contract. But regardless of income, gender, in general, most groups decrease comp by about 40% up to 50% if you step out of the call pool. Why is that important around flexibility? Because if you're gonna ask for flexibility and if you're gonna stop the call, you're gonna pay the price. So one of the most important things about this policy document around flexibility is the transparency around compensation. We can't say we want the flexibility if we're not willing to give up the compensation. So 40 to 50% for no call. Our group is 50%. I don't know what it is here, but it's valued at 50%. And that deters a lot of people. So 1 in 4 cardiologists is over the age of 61. And if you look at the cardiology projections, so there's currently roughly this year about 32,000 practicing cardiologists, 8,400 of us over age 61. You can see the annual FTE losses, and the total number of fellows this year is 3,745. So we're losing 547 a year. We're not replacing with the cardiology fellows that we have currently the number of people who are retiring. So Ritu and I were talking about this a little bit. How many cardiology programs are there? How many fill? How many don't fill? I'm going to show you a little bit about that. But this is part of the workforce crisis that we're facing. We don't have enough fellows graduating who are going to replace the cardiologists who are retiring. So this is not a new problem. We've written about this. Dr. Bruce Fye, who's past president of the college, assembled what used to be called a Bethesda conference in 2004, and there was a growing shortage of cardiologists then. 2009, I was privileged to write with Chair George Rogers about this as well. And so before COVID, we had aging cardiologists in an aging population. The patient complexity and comorbid disease states have grown. We have increased regulation and compliance. We're all aware of that. We're also, again, we were talking about this, how many of the fellows are going into subspecialty fellowship? The vast majority of fellows go into subspecialty fellowship, so we're becoming a very hyper-subspecialized specialty. We're not turning out general cardiologists anymore. We're imagers, heart failure transplant, EP, IC, and adult congenital. So the paradox of our success in interventional EP is chronic disease. So the reason we have so much heart failure at end of life is because we've saved lives with STEMI, VT ablation, et cetera. And so we have this aging population with chronic disease. We're burnt out. I'm going to show you some data on that, and people want to either retire or move into some other career. Okay, here's the fellowship from this year. This is the fellowship match over the years from 2010 to 2021. Only 66, so take 2021, only 66% of those applying for cardiology fellowship matched. You know, the programs always win. Every cardiology fellowship matches, 100% the last few years. No gaps, nobody, you may go down a little farther on your match list, but the programs match. We don't have the GME funding to add the number of fellowship slots that are needed to match these applicants who are very interested in our field. So this is a really important thing to keep in mind and to say to ourselves, where are we going to get the money? The vast majority of GME slots are funded by CMS. I guess that's not true for the fellowship here. There's a sort of a combined funding. But we need to think about philanthropy and other ways that we can train more people. So in 2019, for the first time ever, the majority of medical students were women, and that continues today. And there's also been a slight increase in other underrepresented groups in medicine, including Latinx, Black, and Natives. Why is that important? Because I want to show you what our field looks like now. Not too diverse. Now, this is a paper that I wrote with some of our fellows many years ago, looking at 25 years of what fields do internal medicine residents select. And you can see these are the percentage of women in these fields. Okay, and you can see this gradual upslope. More women, that's right. But which one is ours? Orange, the orange line down there. That's cardiology, flat. So some of the fields, subspecialties of internal medicine are largely women now. Endocrine is, geriatrics is, infectious disease. Those are also much less competitive fellowships. Cardiology has been flat, just a slight uptick, 26% fellows this past match were women. So this is kind of alarming to those of us who are looking at diversity in our field, like what's going on. So we've looked into why this is. But let me show you the subspecialty change too. This is labeled, so 2018's blue, 2019's orange, and 2020's gray, but it didn't get onto that. I messed up this slide. So you can see what the cardiology over on the left, slightly going up, interventional and EP down. Women are not going into those subspecialties, and it's not growing, whereas cardiology is slightly inching up all the time. And adult heart failure or advanced heart failure transplant cardiology, lots of women. But we're seeing people not selecting intervention and EP still. So that's who we are. How do we feel? So this was from the Washington Post recently about the end of ambition for young Americans. The COVID pandemic has influenced the generation of our trainees, our medicine residents and cardiology fellows dramatically. And it's not just people in business who are feeling this lack of ambition. It's overall, the COVID pandemic really changed how people feel. How many of you have heard about quiet quitting? Do we have quiet quitting in medicine? I think we do. People sometimes not going to conference. Of course, they're all here. Thank you for coming. But people maybe not going to CME meetings or doing maybe not as much as they could. And I think this is creeping into sort of everyday life, but I think it's in medicine too. Junior doctors are striking over in Great Britain. And recently in the New York Times, this article said that your doctor, if your primary care doctor was going to follow all the guidelines, she would need 27 hours in a workday. Yes, this clinician who is examining a patient in a corner of a room is embarrassing. Fellows, we lie the patient down on the table. We're standing on their right, okay? But I thought this was interesting. This is a picture they showed. So we're kind of overwhelmed. And this is Daniel Ofri's editorial. The business of healthcare largely depends on exploiting doctors and nurses. This is true. We will take care of the patients. It doesn't matter. We'll go to aside from quiet quitting, we're going to take care of the patients. Our workday extends beyond our work hours. We are in our EHR at night. We know this. We have data that people are in the EHR at night. And so you can actually track it. At least ours, we have Athena, and we can look at data in Athena and see how many people are at 10 o'clock at night doing their charts. We do the right thing. We have not enough clinicians compared to administrators. I actually deleted the slide that shows how many administrators we have compared to clinicians. Everyone's been seeing this slide for years, but it's concerning. So we, the clinicians, are the most elastic resource for the system. So that's part of why we don't feel well. So this is the Medscape Physician Burnout Survey from this year. So they do this every year, and lots of people are burnt out. Look at emergency medicine at the top. 65% of these people feel burnt out. The blue arrow is us. We could feel good about this graphic and say, well, only 43% of us, 43% of us are burnt out? That's a lot of people. We are subspecialists. You know, we have trained and are doing, hopefully, the work that we trained for, but we're still feeling really burnt out. Women are way more burned out than men. We don't have it selected out to cardiology, but keep that in mind. And what do we think would help? This is what these burnt out folks would help. Okay, increased comp. Okay, that always helps. But number 2, flexibility, a more manageable work schedule. So I was really struck by this. You can see the other, and they could select multiple answers, but number 2 was more manageable work schedule. What have you done to alleviate your burnout? Number 1, reduced work hours. That's flexibility. Number 2 is meditated. Okay. But 21% changed job or work settings. So again, flexibility, if you think about flexibility as a way to address burnout, I think it's important. So every several years, the college puts together a survey and surveys the membership. And if you ever get a survey like this, please respond because it's really important. And the last professional life survey actually looked at the differences over 2 decades. So we were able to compare one survey versus the next survey. So it was over 2 decades. What did we find out? So there was little to no change over 2 decades in career satisfaction, discrimination, those who have no children. So fewer women have children than men. That didn't change. Those who require child care help, and those who are single. More women single than men, 14% women, 5% men. What did change over 2 decades, on the right, more people are over the age of 50, both women and men. Look at the downward tilt to the private practice, the same data, similar data that I showed you before. And then having responsibilities that impede professional travel. So it's really important to think about, again, this is another look at our profession. We're an aging workforce. Men are now balancing career and family more similarly to women than previously. So we know that flexibility is not something that just the women want now. I like to say women were the canary in the coal mine on this issue. How many hours a week do we work? We work a lot. The vascular surgeons are at the top, but you can see where we are. This is compared to hours above or below an average family practitioner. So those on the right are above. So we work a lot. We're about 11th on this survey. So we work a lot per week. And we're burnt out. So this was a totally different survey led by Lakshmi Mehta, looking at burnout and career satisfaction among United States cardiologists. And this is figure 1 from that data. And I think what's most striking is are the golden bars, which are in the back, which are labeled as completely burnt out. So these cardiologists said they were completely burnt out around job dissatisfaction, misaligned values, no control over their workload. You can see all the other hectic work environment and excessive time on the EHR. So this is us, this is our field, this is how burnt out we're feeling. And so those are completely burnt out. And look at the blue bars in the front. Very few people said no burnout at all. But even those said they didn't have enough time for documentation. What about mental health? This is a newer paper led by Garima Sharma. What about mental health conditions among cardiologists? This is actually an international view, and I'm not going to go into this in detail, but the prevalence of mental health conditions worldwide in cardiology is pretty significant too. I chose not to use data on suicide rates because it's not specific to cardiology, but I think we all know that physicians have higher suicide rates than other professions as well, especially women physicians. Hostile cardiovascular workforce environment, very common around the globe. Hostility, be it sexism, racism, overt hostility. This is a different survey, but showing us across the world that the cardiology workplace can be a hostile space. Okay, so that's uplifting. Wasn't that uplifting, everyone? So how is our field perceived? I showed you like how burnt out we are, what our lives are like. How do internal medicine residents perceive our field? So back in 2018, we took a look at this, surveying internal medicine residents saying, what do you think? What do you think about cardiology versus others? Adverse job conditions, huge. This is the view of internal medicine residents. Interferes with family life. It's not diverse. I don't have any positive career role models in that field. Compensation actually wasn't viewed poorly and very intellectually stimulating, so that's good. On the bottom, men versus women, you can see that women felt these things more strongly. So our field is not viewed positively, in particular around adverse job conditions and being attractive with regard to family life. So that was 2018. What about now? So Megan York with senior author Melissa Wood looked at this again, and just recently in the last 2 years surveyed medicine residents again and looked at the trends over decades. And this is what people want. Even more people now on the top left want stable work hours than wanted them before. This is on every item, it's 2010 versus 2020. Everybody still wants a family-friendly job. People want positive role models. We want some compensation, professional challenges, et cetera. So again, even over time, we're seeing the need for stable work hours and a family-friendly environment, because we know that there are internal medicine residents who don't even think about cardiology. Probably those of you who've come to this lecture today are thinking about cardiology. We hope you are. What about interventional cardiology and the perception of women? This is data from Dr. Young showing us that in men, largely, many more men intend to pursue interventional cardiology than women. More women are clinical cardiologists. Look at EP, many more men. So part of this paper talked specifically about the cath lab culture, and it was not felt to be friendly to women. By the way, when this paper came out, I assembled our women fellows and said, what's our cath lab like? And I was happy to know that they said it's more than welcoming. They've never experienced some of the things that they've said. So general cardiology isn't really viewed as family friendly by medicine residents, and interventional and EP aren't really viewed favorably by women. So that's how we feel, that's who we are, and why does career flexibility really matter? I've been writing about this for a long time. This is a newsletter, a Women in Cardiology newsletter from 1999. I found it for this slide. But I was like, you know, I've been kind of at this for a long time. And in this newsletter, I interviewed several people who had had some sort of flexibility built into their career. One of them, just as an example, Janet Wright, who was a former trustee of the college and now works for the CDC. She worked for a 5-person cardiology group in California. And she decided a few years in, she was going to take an afternoon off. Well, this was met with like horror on the part of the other 4 people. And she was like, I'm leaving my pager on. But if anything happens, like somebody needs to be hospitalized, I will assume you will cover for me as you would if I were on vacation. And within 2 years, every single one of those cardiologists took an afternoon off. She changed the culture. And so even back this long ago, I was able to find people who had made some sort of change in their schedule that allowed for more flexibility. So let's get to the policy statement that the college put out. So when the American College of Cardiology puts out a policy statement, it is because the college believes that there's a question that has been left unanswered, or that there's something in the environment, usually in the United States, that we need to push for policy change. That could be federal policy in some cases, but in this particular case and in other policy statements, it's to shift us, to shift practices. Universities think about things differently. How can we make change happen? So I want to tell you about the writing group, because one of my colleagues said, well, I read that whole paper and I thought it was just written by a bunch of old people. And I said, no, it was not written by a bunch of old people. So I want to tell you who the people are. Jim Arrighi is the current CEO. He's a cardiologist. He's a past program director at Brown. He was the residency review committee chair for the ACGME for internal medicine. And now he's the CEO of International ACGME. He knows everything about training, about the ABIM, ACGME, and the issues that fellows face. So he's one of the writers. Joe Cashone and John Warner are both system leads. They're both cardiologists. Joe Cashone led Ascension as a vice president. He now has taken over as CEO of Jefferson Health. John Warner, who's on the bottom right, was CEO at UT Southwestern, now moving to Ohio State. So we needed the administrators. We said, okay, you guys are cardiologists, but you have this system view. And we knew we had to have that viewpoint in order to write this. Annalisa is a program director. Pam Douglas, you all know, past president of the college. Claire Duvenois, chair of cardiology at the VA in Michigan. Joanne Foodie, a cardiologist who went into industry. So we needed that perspective. Sharon Hayes at the Mayo Clinic has written a lot about transitions in career, and so we included her. Dipti Ichapuria, one of the immediate past presidents. Mike Parmasek is chair of medicine at Penn. He's a chair of medicine and a cardiologist. So we wanted that level of, how are we, what about flexibility? How do you view it as a department chair? Ada Stefanescu was a fellow at least at the beginning of writing this. And then there are two older guys, both George and Thad are at career, nearing the end of career. So we had it all. So we really had a lot of stakeholders clearly selected for certain parts of life. So this is neither what women want, what people at end of career want. We kind of included all perspectives. So why do we need flexibility in cardiology? I've already told you several of these bullet points. Burnout, we work hard, we're one of the hardest working fields. But also, flexibility can address diversity and inclusion in a way, and I'm going to show you why. This is the ACC's current strategic plan. There's another strategic plan going forward from 2023 into 5 years from now, but this is the current strategic plan. And what I'm showing you are the strategic goals and key strategies. And in the left bar is the goal of increasing relevance as the cardiovascular professional home for the entire team. In order to do that, we have to increase member diversity and inclusion and promote clinician well-being. And we know that flexibility in the career can address this. So I'm tying this back to our current strategic plan because it matters. We don't just go off and write policy statements based on, oh, we thought we'd put a writing group together and address this topic. This was aligned with our strategic plan in the college. The goals of the policy statement are to provide solutions that allow both women and men to reconcile training requirements and the demands of practice with parenthood and family life. So we know that we need to increase flexibility in training in order for people to take leave when they need to. And currently, this actually just came out a few days ago. These are not cardiologists, they're not cardiology, they're actually, I think, women who are in mid or later career, and they talked about pregnancy and residency in the New England Journal this week. Many times when people take family leave during training, it's viewed as a favor. The call is covered by others. Sometimes people have to pay call back. These are all disincentives for people becoming parents during training. And this paradigm really has to change because infertility in physicians is huge, partly because people wait through the training period. So this was a call out just this week. This isn't just in our field. And I want to show you, I think, well, I'm going to get to what we can do in training, but one of the things we have to do with regard to training and how we can achieve career flexibility is when we're training fellows in internal medicine residents, right now, the ACGME requires an ABIM requires a certain number of hours that you're doing whatever it is. Let's pick the cath lab. You've got to be in the cath lab X amount of time in order to learn that. Two things. One, what if I don't want to go into cath ever? Do I really have to ever enter a cath lab in my cardiology fellowship? Or if I'm really good at it, can't my attendings say, great, done. You don't have to do additional. So we need, where the blue arrow is, the movement towards competency-based rather than time or volume-based is really important in our training. These are the structural barriers that are put up by the ABIM and the ACGME. And this is table 3. So I invite you all to read this when you have time. But we need to consider alternative options for certification that's based on flexibility around MOC, around CME, but also just around competency, where we as attendings and program directors can actually stipulate that someone's competent without saying they have to, X amount of time in this place or that place. There are people who extend their training because of parental leave very routinely. Is that necessary? Not if we're in a competency-based system. We also have to achieve predictable work hours. I already said that, so the second bullet is impact on compensation, we clearly have to be transparent. You cannot have flexibility without changing your comp. And this is something that when a paper like this, when a policy document goes to review, you get all these comments back, 10 reviewers. And and for the first time, it was blinded. So usually you would get like the 10 reviewers, you'd know what they were, who they were, what they were saying. I knew one person was an administrator. I could tell. It was like, no, you can't do this, you can't do that. And so we had to modify and kind of fight back, but it was all about comp. And so we have to be transparent about this if we're going to do any of these things. If we're going to have professional societal leadership. I took the opportunity and I was privileged to be the president of the ACC. What happened at my work? Did I still get paid? One of my colleagues said to me, wow, one of my younger colleagues said, how many RVUs did you get to be the president of the ACC? And I said, you don't get RVUs to be the president of the ACC. You're absent from your work. We came up with an equitable solution for that. Not every group would have done it. Some people who've taken on professional society leadership, I know this for a fact, have paid back call for 3 years later. So these are workplaces that are less flexible than perhaps mine. One of the things about roles in industry we addressed in the document, Dr. Foodie was very helpful in, because people like to transition from one role to another and sometimes overlap clinical practice with roles in industry. There are a lot of barriers to retraining. If I wanted to, for example, become an imager, I can't do that anymore. We used to be able to kind of go back and forth like that, but now, you know, if I wanted to become an echo reader, which I'm not, I want to be as good at it as everybody is who trained in it and take the echo boards. Lots of barriers to retraining, so that decreases our career flexibility. We have a huge problem in career deceleration. Some practices and institutions do not allow for people to come off call or decelerate in their clinical responsibilities in any way. One friend who wanted to simply step out of the call pool in his practice and continue as an active interventional cardiologist, full clinic, full cath, just no call. His group said no. And he left. They didn't retain a senior cardiologist who, to some extent, was a rainmaker in getting patients into the practice. So if we have those draconian policies and we don't have an ability to slow down at the end of career, we're going to lose more people. And remember how many FTEs I said we were losing? We're going to lose more people because we have these policies. Our group, you can stop call at 55. Don't know what it's like here, but that keeps enough people in the call pool that we can still run the ship, and it allows people to have a little bit more flexibility. This year, 3 of our early career men requested to go to 0.8. We said, actually, one of the leaders of our group said, well, I guess if we've let women do that, we have to let men. I said, yeah, unless you want the lawyers here. So I wonder, and I've brought this up to our group, maybe this should be our new contract. This is maybe how we should open. 0.8. That means every week you're not on, they have to take full service, full call, full inpatient. That means you have a day off on the weeks you're in clinic not doing inpatient service. Why wouldn't we offer that as our just opening bid for a new faculty member? At the bottom is team-based care models. We know that team-based care increases flexibility in the workplace, and I want to show you just a little bit about that. We know that people should be working to the top of their license. I'm proud of the college, again, for having been historically looking at team-based care long before we had a CV team section and council. This work in heart failure was in 2005, and in order to better understand how heart failure teams work together, they went out and visited all these practices and found out, how are you using teams? We were one of the practices. So this went back all the way to 2005. We also looked, this is a paper led by Mariel Jessup, and we looked at who are in the transplant teams. We knew we probably needed to better define what is team-based care in advanced heart failure transplant cardiology. And so we looked at the average US staffing by practice size to see who the clinicians were and what type of teams they had, whether they had pharmacologists, et cetera. Why was this important? This was important because we were laying out a template for practices and institutions to be able to go forward and say, this is what other people have. This is what we need at our institution. This is what we need for our team. This is a fascinating single practice look at working to the top of your license. When you work to the top of your license, that means that you're doing, as an MD, you're doing diagnostic, you're thinking, you're doing procedures. You're not doing work, except in the EHR, I hate to tell you, we're all not working to the top of our license when we're typing, right? We didn't used to type as much. But this practice looked at who did the pre-visit chart review. That chart review is ideally done by a medical assistant. The pre-visit chart review is, you know, patients coming in, were they admitted to the hospital recently? Do I need to get documents? That is the role of a medical assistant. But look at 12% of the physician, 12% of the time the physician was doing it. If we don't work to the top of our license as a team, we're not going to be functional. And if we don't have good team-based care, we're going to decrease the flexibility that we see in our workplace. So the end of this policy document is 18 principles that we've called out as the college to say, this is really what institutions and practices have to look at. Cardiologists should have flexible work environment. They should, over time, we should be able to provide the most value possible over our career span without being, we should be able to stay if we want to stay, even if we're not going to take full call. There should be policies in the workplace that protect us. HR is present with us wherever we are. That applies to all the employees here in this health system. But there have to be transparent policies in cardiology regarding options. This should include the entire span of the career, from training all the way to later in career. And those who, I didn't mention this yet, but many people who have laboratory-based practice, interventional cardiology and EP, need to transition to a different opportunity just because of the physical demands of that work. And they should be allowed to do that, go to office practice if they've wanted to step out of the lab. So human resources departments have to be involved. There should not be what we called unwarranted systemic differences based solely on hours and work type. That's calling people part-timers. And I'm sad to say I've actually heard this word used for the three men I told you about. It's a little bit of a spin, in our practice, and I've kind of challenged people on saying that. So like working 0.8 as a part, that guy taking full call, et cetera, et cetera. So those are unwarranted systemic difference. People should not be unfairly penalized, but compensation matters. We have to account for that. And then for people who want to reduce hours temporarily, they should be able to come back to full practice. And I think this is my last slide. Cardiologists really need to have supporting workplace flexibility. This is the leaders. And we asked the chair of medicine and the administrative leaders what they thought about this, and they absolutely agreed that they should be held accountable. That is not happening everywhere, and that's part of the reason that this policy statement was put in place. I already told you that training programs need to change. We also have to look at subspecialty fellowship flexibility. We only have 1 year for IC, interventional cardiology, 1 year for advanced heart failure, now 2 years for EP. But we have to look at fellowship training in the subspecialties as well. Aging cardiologists should be able to practice and fully engage if they wish to. We know, and we talked a little bit about this last night at dinner, we know that as we contract work hours for either early career or late career, the practice is still covering in general medical malpractice, all the overhead that you would have in the office if you worked full time, and full medical benefits. So if everyone today contracted down to 0.6, it'd be not sustainable, right? So we have to understand, as someone transitions, either early career or late career, that sometimes, even though the practice may benefit in a way because they're actually decreasing what they're paying the individual, they're still they have significant cost with med mal and other coverage. And lastly, we have to talk about fatigue. So most practices still have night call and then work a full day the next day. This has changed in some circumstances. We actually have STEMI call in our practice. The interventional cardiologists do 1 week at a time, and then during the morning hours, they don't have clinical responsibilities. They don't have clinical responsibilities till about 1 p.m., and they do some clinic, and then they start that call again. It's very innovative. It is not the norm for interventional cardiology. Just a random sample of hand raising in a recent meeting showed that the majority of interventional cardiologists work a full day the next day. So do surgeons. So we have to protect. Part of workplace flexibility also has to address the fatigue post-call. And I'm going to end with that and look forward to discussion or cat calls or anything you have.
Start with an online question.
Oh, okay.
That works.
Good.
Dr. Walsh, thank you so much for your time this morning. Great to see a room full of people here. So the first question comes from Dr. John Lesser. And he asks, well, first he says, great talk, but then asks, how does your group deal with the possible lack of individual involvement with the group when someone decreases their time? And furthermore, what are the trade-offs for the individual who drops back on time?
So I would say thank you, John. I wish you were here. John and I've referred many patients. My family is here, so John has seen many of them. So our group generally, I will say that our group is really evolved into this, and we have very clear step-down policies, and we established them a long time ago, and I think that's what has protected us. You can't just on the fly decide what call's worth, or on the fly decide how much. If somebody comes to us and says, I want to decrease my work days to whatever, it has to be very intentional. I would say that the engagement has remained, though. We don't see a lack of engagement in people who are working less than full-time or have a more flexible schedule. In fact, we have an opposite problem. We have a problem of our senior-most cardiologists wanting to continue on way beyond age 70 and still do office. And I know, Bill, you said last night you'd love to have people doing office forever and ever. But one of the things that happens is that, I'll tell you what happened in the pandemic is there were a few people, 2 or 3 people who said, I'll just do telehealth visits from home from now on. And we said no to that. We said, no, that's not a full practice. We get it, that would be great. But we're not going to, that means you have an MA who's a medical assistant and a nurse who's partnered with you, not maybe exactly at the same time you are, but that's really throwing off all the other people who are in the office now and where the overhead is shared. So we haven't seen a lack of engagement. That's the one guardrail I think that we've put up. We all do occasional virtual visits still, but solely having your end of career practice be, I'm going to be in my kitchen doing virtual visits, we said no to that as an option because we didn't think that was full engagement. I don't know if that answered John, but drive safely.
That was a great talk.
Thanks.
So one of the concerns, I think, when people go to part-time is who's going to cover the in-basket, right? So
Yeah.
I think for those of us that have a lot of clinic, you know, we're always sort of attached to the in-basket, even on vacation. So I'm sure there's concerns, but how is your group handled as people transition to part-time? How's the coverage work during that time?
I would say that this is the biggest issue we're all facing, and it's not just if you're less than full-time, it's when you're on vacation. We don't have the ability in our EHR for an away message. Do you? You do? We don't have it in a theater.
I'm not aware that I was trying to do that last week and I couldn't figure it out.
It's hard to turn on.
Yeah. So, do you know the secret of how to turn it on?
I can find out.
Oh. So we have more of an agreement. So we individually can say, hey, will you watch my inbox? But we don't actually have any ability to stop the flow. So in general, we cover our own EHR when we're gone. Like, so today, I was traveling on Friday. I didn't look at it at all, and it's making me nervous. That's the it's like, well, when I get to the airport, I'll probably open it, but then it'll be a HIPAA violation, and you know, you go through all this. But by tomorrow night, I'll be totally caught up. And we also have a thing on our phone that if a nurse wants to get us for something more urgent, they can do that. But I would say we generally cover our own, whether on vacation or whether on that, you know, if one of the 0.8 people is off for a day, they're still responsible for that. But we're very public about who's every day, who's here and who's not here. And so the nurses generally are pretty savvy as to asking another person who's physically present if there's an emergency. I mean, you can't put an emergency in a text or something like that. Peter?
One of the things I was struck by was even in the people with no burnout, the documentation requirements and sort of the EHR burden seems like that. I mean, that's a big deal even for the self-identified not burned out people. Where do you see that going? Do you see relief on the horizon? Is it time for should all the physicians get their pitchforks and fight back and say we're done with bloated data diarrhea notes? I mean, how do we make this better?
It's a great question. We tried scribes, we tried a pilot, and a few people had scribes to see if they could see more patients. They could not. So if you want a scribe in our practice, you have to pay for that scribe yourself. So that's one way of dealing with your own. Now, some people have, and they say they love it because their charts are up to date with, by the time they go to the next room. Some people are now talking about, how the Cleveland Clinic came out and said that they were charging for online portal messages. That's true in other health systems too, and I think that's going to stop patients from, it'll put a little bit of a barrier to some of the questions that come that maybe don't need to be answered. Now, in our EHR, we have the ability, I'm partnered with a nurse, and the patient portal questions go to the nurse first. I don't know if that's how you have it.
That's what we have.
Right, not everybody does. Some people said no, they have no ability to protect from the patient question, which there's ways to do that. So I think that's one answer, is to filter out the easy questions. Can you refill my prescription? Doesn't have to, that's not working to the top of your license. But I think a bigger issue, it's constant availability. The EHR is always a burning flame over here that you have to deal with. But the other thing, especially for, I think, older physicians, is most of you who are younger type really fast. And not everybody does. And there's still, some folks in my practice who dictate. And we still allow dictation, but that's going to probably end pretty fast too. And I think that's a big burden. So I think it's very layered, but I don't know that the EHR is going to go away. I mean, it was a federal mandate that was put in place, that and electronic prescribing and everything. And there is a level of patient safety because of it. And just to reflect that the burden that used to exist, if I were gone for a week before EHR, I would have to come back on Sunday and actually address paper charts that were piled up, because you couldn't come in on Monday and expect to do a full clinic and not have dealt with whatever these piles of charts were. So there's always been work to come back to, but I don't see it changing much unless we put things in place like, I do think the Cleveland Clinic model is like, well, if you're gonna ask us and you want a doctor to respond, we're gonna send you a bill, and I think that'll change.
I think the other part of what I'm wondering is, do you think there's hope for being able to focus documentation a little more? I think of my grandfather was a family physician. He would have a single note card. Every visit was one line. You give 10 years of someone's medical chart on one. Obviously, that's not practical now, but it seems like a lot of what gets documented is beyond what's needed, both to 100%. Sort of protect yourself and convey your thought process.
I'm a fan of getting rid of dot phrases. I mean, some charts you cannot even figure out what, and I'm going to pick on my EP colleagues. Sorry, Bill. I know if you're discussing an ablation with a patient, I totally get that you want all the dot, or a primary prevention defibrillator, totally get it. You want all that in there legally. I cannot figure out sometimes, what did you decide? Wait, where is it? What you got? You and the patient decide down. Is it way down here, way up there? Because it's like, and it's beautiful for billing and coding.
And the lawyers.
Right. Yes, I had the whole time. But I do think dot phrases add to, and then if you copy and paste from your last note, and the dot phrases are all still in there, it becomes even more. Are you referring to a hospitalization that just happened, or was that a year ago? Things like that. So I don't have an answer, but I think is it your grandfather you said was it? Yeah, those notes were great. You could tell what he thought, what the patient had, but sometimes now we can't.
What does your group feel about clinical research as far as, is there protected time, or is if you want to do research, you just do it on your own time?
Big question. Some people have elected to have some administrative time for research. We have yet to hold those individuals to some sort of a metric like, well, are you doing research then? Are you more productive? But they're actually, any administrative time we take for research, if we take a research day, their RVUs suffer. So you have to be willing to, if you say, I want to be productive in my research life and write papers and do investigator-initiated research, then you have to be willing to, at the end of the day or the end of the year, have accumulated fewer RVUs, or what we call time value units. So I would say the majority, we talked about this last night too, the majority of very productive researchers in our practice do it at night and weekends, which is true, I think. Whether you're funded, whether you got an NIH grant or not, people who love research are always writing. So, but we do have an ability to, if you're aiming towards research, you can request that time.
We have one final virtual question. I know we're at time here, but if we could just do one more here. So this question, they ask, I work in an academic multi-specialty practice. And the question is, how do we make a case for our flexibility for cardiology when other divisions are also undergoing burnout?
Everyone should have flexibility. I mean, we can just talk about our specialty because we're in it, but one of the specialties that I really admire for how they've evolved is OBGYN. So when you think about that specialty, they are majority women now and have been for a long time. And along with that, what's happened? They've been innovative in how they cover their service. They now have laborists. Pretty common in most hospitals, where you don't, at night, have to cover for your own patients and deliver babies. And if you're an early career person and a parent yourself, you might, like one of my colleagues' wives is a laborist 3 shifts a week. I think at night mostly. So there's a field with heavier call burden than our STEMI call, right? And look what they did. So I would say, you know, every field for itself, because we have to all demand it, but other, you know, call like GI, there's other surgery. I mean, look at the surgeons. You know, our cardiothoracic surgeons will operate on a dissection at night and do valve surgery in the day. It's insane. Sometimes they cancel, you know, if it's an elective case and they've been up all night. But I think just because others aren't asking for it is not a reason that we should move forward. It's a great question. Thanks for having me.